go ahead and get started. It is a little bit after 6. We may have a few more people jumping on this virtual health and wellness series. My name is Gail Clark. I'm the Director of Marketing and Community Relations. Tonight we have Dr. Fitzpatrick joining us. He has been with Littleton Regional Healthcare for about 11 years. He is a ear, nose, and throat specialist. He also specializes in allergy medicine and facial plastics. We're very fortunate to have someone like Dr. Fitzpatrick on the medical staff because he brings such a vast experience to the area. I'm going to just take a minute to tell you a little bit about the virtual health and wellness series. We're offering them on a quarterly basis, and we do invite participants to let us know what topics they would like to learn about. And you are welcome to email either Heather or myself, and we will follow up with an email after probably in early December to all participants. These health and wellness series, they're sponsored by the LRH Auxiliary, which is a group of volunteers who raise money for Littleton Regional Healthcare. We're really grateful to them for their generosity so that we can continue hosting events like this. And now I'm going to introduce you to Heather McKean. Heather is our marketing manager. She is going to be moderating tonight's meeting. So Heather, do you want to take over at this point?
Sure, thank you, Gail. Everyone should see the options at the bottom of their screen for chat and a Q&A function. Either of those will allow you to submit questions or comments throughout the presentation, and I'll keep an eye on it. At the end of Dr. Fitzpatrick's presentation, we will work through any questions that have been submitted. And with that, I will turn it over to Dr. Fitzpatrick.
Hi, everyone. Thanks for joining us. Thank you, ladies. Thanks for the introduction, Gail. I'm Patrick Fitzpatrick. Again, I've been here 11 years. My family and I moved here from Detroit 11 years ago. We've raised our 3 kids and still raising them. We live in Franconia, and we're happy to be still a part of Littleton Regional Healthcare. So I don't want this to be a boring opportunity. I want this to be very open to questions and answers, and there's no silly questions. So please type those in or stop me throughout the brief presentation we'll have. And I'm looking to make this practical and kind of set a foundation for some of your allergy questions. So tonight we're going to talk about kind of what allergies are, why do we have them, and why do they seem more common today. We're going to start off with a little quiz because it's always nice to ask some questions versus me just talk to you guys. So, you know, you can answer these to yourself, but true or false, you know, 1 in 10 Americans have symptoms of allergies and or asthma. I think I sometimes have a skewed vision of how prevalent allergies are because that's what I do on a daily basis. But actually, about 50% of more like 25 to 30% of people will have allergies throughout their lifetime, whether it's in childhood or adulthood. There is something that we see commonly in adulthood. You know, there is adulthood onset of allergy, which is hard for some people to grasp because they commonly associate this with a pediatric or childhood process and feel like if they didn't have that early on in life, why is this happening now in adulthood? And we can talk about that a little bit, but it's very prevalent and it affects millions of people in this country annually. Thus all the commercials on TV that I'm sure you see for drugs and over-the-counter remedies for allergy. Second question, the likelihood of having allergies is determined solely by one's genetics. I think a lot of people may say yes to this. I think the genetic predisposition. So the answer is false. There is a strong genetic link or family associated process where we usually estimate if one parent has allergies, their offspring or children are likely about 50% of the time to receive that. If both parents have a history of allergies, it's closer to 2/3. So there is a strong genetic predilection, but just because your parents didn't have allergies doesn't mean that you're going to escape life without those sensitivities. One last final question. Allergies can be cured, true or false? And the answer again here is going to be false. Allergies can be modified, which we will talk about. They can be controlled with medicines or long-term treatment, but a cure for allergies is hard to come by. And we'll get into kind of why you have allergy, reactions and allergy symptoms. So those were just some questions to get the mind, going. We're going to really talk about, what is an allergy, and it's a abnormal reaction to something that is very otherwise harmless that your immune system perceives. So it's a hyperactive response from someone's seemingly normal immune system, and it's an overzealous reaction that leads to a lot of classic allergy symptoms, i.e. runny nose, drippy nose, sneezy, congestion. The slide here has some of the most common food allergies, and we're going to talk tonight about environmental, food, and drug allergies. But the most commonly food issues for true allergy are those listed. So if someone comes into the office and says, you know what, I think foods bother me, I don't really know where to start with that, in terms of they don't have a list of foods that they're overly concerned with. The 8, we call these like the 8, hidden foods. They can be in a lot of foods as fillers, especially soy, wheat, and egg is in a lot of food that you wouldn't otherwise think is in there. So again, we're going to really focus on environmental, foods, and medications. The environmental process, environmental, kind of the definition of that means anything that you encounter in your environment, whether it's inside or outside. So that can be pollen from trees, pollen from grass, pollen from weeds. Mold can be in the environment, especially household plants have high mold content. Animal dander is a big trigger for people, most commonly cat and dog. We in the clinic also have a lot of people that work with horses, so we can test and treat people for horse work as well. Stinging insects, we have the ability to work through that workup. And then dust mite is another big one that people sometimes forget about. And it's not the household dust that you often see. It's not the dust bunnies on the floor or the baseboard. It's the dust mite that exist and thrive on fabrics. For instance, pillows, mattresses, curtains, carpeting. Those are the big kind of factors that house and foster dust mite. In terms of food, so before we go into food, environmental symptoms are very classic, and those are the things that people always think of, and it's the itchy, sneezy, congestion. That workup and that evaluation to test and to identify that is very black and white. It's straightforward. From an ENT allergy standpoint, which is what I practice based on the American Academy of ENT Allergy, it's preferred to proceed with skin testing, and we have an environmental panel, it's called, that we evaluate people for common things in their environment specific for the upper Northeast. So we're not obviously concerned about things elsewhere in the country, other than things that we come into contact every day in our normal environment, which our immune system may think is harmful, and it has this reaction. Foods is a completely different animal, and I get a lot of food questions in my clinic. And food allergy is very confusing to some people. It's very difficult to work through. And unlike the environmental process, it's very hard to nail down. A lot of people clump food allergies into this big bucket that includes everything from reactions related to GI distress. So I'll have patients say, well, I eat something and 2 or 3 hours later, I'm really bloated, or I get constipated, or GI symptoms are typically not a sign of true food allergy. So food allergy is pretty specific to you consume a food, you have a reaction within 15 to 20 minutes, and it's typically within the airway and or skin. And that can be hives, swelling, a sense of swelling without anything, visible. Itching can be common, and that can be progressive with future exposure, which will kind of explain, why these happen. Everything other than that kind of food reaction, we kind of clump into food sensitivity. And food sensitivities are not easily diagnosed by any skin test or any lab test. And I have this discussion with patients every day, and it's hard for people to kind of understand that food sensitivities, although foods may not agree with someone, whether it's a GI reaction or exposure after consumption, the best way to figure that out is by kind of tracking what you consume and trying to link that to symptomatology. But there's no test that's going to prove that food sensitivity. So it's crucial that if people are talking about food reactions, to really distinguish between allergy and sensitivity. And sensitivity is a very large struggle for a lot of people without a lot of concrete test results that are available. Medications, I think, would be the third common questions that we have in the office. Medication testing is very difficult as well. We don't do that on skin, we do that on blood. So via blood work, we take a sample of your blood, we send it to the lab, and there's usually a radioactive test that we can perform, but we're very limited to how many drugs we can look for. So we can't often test for anything other than very common antibiotics and very common, medicines that are used, including sulfa and penicillin. But the more finicky medicines you come across, it's going to be that relationship to intake versus symptoms. In terms of chemicals and topical exposures, there is a process called patch testing. We don't do that here locally, but we work with our partners at Dartmouth, to get that organized. So I think those are the three big kind of buckets that you think of: environmental allergy versus food versus medication. Any questions so far? If you have anything, just buzz in, and Heather will let me know, what we can answer or clarify. Common symptoms. So as we kind of divide this up, the classic airborne allergy or environmental allergy, again, is sneezy, itchy eyes, throat, nose, nasal congestion, and coughing. It's important to remember that we describe this phenomenon, what's called a one airway phenomenon. So when you inhale allergens from the environment, they don't simply affect your nose or your sinuses. They actually continue through the airway into your lungs, into the pulmonary tree system, and equally can affect your lungs and leading to wheezing, coughing, shortness of breath. So remember, those can be also common signs and symptoms of environmental allergies. So those allergens that you breathe in, again, whether you're sleeping with bedroom windows open and things are blowing in all night, or you're camping, or you're cutting the grass, equally affected are your lungs, just like your nose and sinus. Food allergies, we talked about itchy mouth, hives, rash. The bottom three, the cramps, nausea, vomiting, that can be a sign of allergy if it happens immediately after ingestion. But most of the time, when people complain of GI symptoms hours later, it's more food sensitivity. And then insect venom, allergies is significant and severe, and that often leads to difficulty breathing, hives, and throat swelling. And we can help people evaluate for that. Again, we can offer immune therapy for that, so that's not as risky as well. And we'll talk about that in the treatment section. So when we talk about allergies, how does this all work? Why does this happen within our immune system? And this is I'm not going to belabor this picture, but I just want to call some basic principles. So if you look up in the top here, these yellow little balls is an allergen, whether it's a birch pollen or a cat dander, something that you inhale, comes into your system, often through your nose and or your mouth, and it will enter and kind of interact with what we call the mast cell. The mast cell is the classic immune cell that we have in our system, and these will be kind of alerted to this allergen, and these cells then create and release what's called immune globulin. We have 5 immune globulins in our immune system, and this type of allergy reaction deals with what's called our IgE, or immune globulin E. When the allergen then hooks to these IgE mechanisms, then we have a release of histamine. Histamine comes from the mast cell, and histamine is what leads to the classic itchy, watery, sneezy nasal congestion. So that's why we use antihistamines, which are now mostly over the counter. So the antihistamine drug, for instance, Claritin, Allegra, or Zyrtec, that will help to block that histamine release, which then helps prevent the symptoms. But that's really all it does. It doesn't stop this reaction. It just helps to prevent the release of histamines. And then the histamine will affect many different parts of your body. It can affect your organs. It can affect your GI tract, along with your nose, eyes, throat, and lungs. Last picture we're going to talk about from a kind of an immunology standpoint, this is an example of ragweed pollen, which is high right now. So fall time is high peak ragweed season. So let's say you come into contact, your first time, allergy prone person runs into the allergen like ragweed. The ragweed binds to the B cell. It makes these large amount of IgE antibodies, and it leaves these molecules on the mast cells. So some people with first-time exposure don't have many symptoms. However, this first-time exposure primes the pump. And then a second-time exposure with ragweed, the system is already created, and these IgE molecules receive that allergen, and then your symptoms start, which is all, again, the histamine reaction. Often the environmental reaction then stops from there. What's different is drug reaction and or food reactions, if they're true allergies, can escalate and become much more significant. So third and fourth exposures can be very different from prior exposures and can be very much more extreme, and it can oscillate. So food and drug reactions aren't as predictable as environmental. Environmental reactions often never cause an airway crisis or an airway emergency. So you'll hear people that have like an EpiPen or epinephrine for safety. That's almost always for food or drug reaction, not for environmental reaction, because your system doesn't get as excited. There's not the risk of airway loss with those exposures. This slide talks about kind of an allergy prone person. What is an allergy prone person, or what does that mean? This kind of goes back to the family link to allergy, but also this definition of atypy. Atypy kind of means, in our business, the genetic predisposition to develop allergies or allergic diseases. We talked about the risk of parents, and again, if one parent is atopic or has a propensity to be hyper excitable, that's another way to think of it, is their immune system overreacts, becomes hyper excitable, and then we have symptoms. About 50% of the time, their children will have it, and if both parents have it, it's about 2/3. So there's a strong correlation that can lead to recurring sinus infections, recurring ear infections, asthma, and we see all those, later in life disease processes come from uncontrolled allergy. So this atopic march, or this propensity to be hyper excitable, often begins in childhood. It will start with eczema. Actually, eczema is a clear sign that if infants or young children have eczema, that there's this tendency to be hyper excitable. Then maybe between age 4 to 6 peaks allergic rhinitis, which is often environmentally related, where people will have the classic itch, water, sneeze. And then if unchecked, that atopic person or that predisposed person then will likely develop asthma. So eczema, allergy, and asthma has a clear relationship. And our goal treating allergy is not only to make you feel better, but to really stop that cascade of significant chronic disease, because asthma is a long battle that needs pulmonary steroids and pulmonary management and leads to a whole host of other issues. So this kind of reiterates the one airway link, that things that bother your sinuses and your nose are very closely related and can also bother your lungs long term. So that's really the goal that we try to help people with, is to stay off this escalation of disease. There's many environmental factors that kind of lead to allergy, and there's always a question of, is allergy more prevalent now, or is it just more recognized? And when I talk to patients that are 40 to 60 years old, I don't think I'll ever find someone that tells me their parents had allergy. But then you think of their parents that would be now 80 to 90 year olds at that time were not worried about a sniffly nose or nasal congestion. They were worried about having a job. They were worried about having the next meal. And there was bigger concerns in life than maybe allergy symptoms. So I think we as we've grown in our society, we've expected kind of symptom-free life, and we pay attention now more to maybe more subtle things that people that lived through the Great Depression or World Wars weren't necessarily focused on at that time. There is a common phenomenon that this hygiene hypothesis. So the cleaner you are as a child, the more propensity or the more risk you may have to develop allergies down the road. And that is proven. So a lot of people say, let your kids get exposed to that early on. Kids need to play in the dirt. They need to get sick. That kind of leads to immune development. And there is a strong, correlation to industrial nations have more issues with allergic, disease than those in developing nations. So that's one large environmental factor that affects us in the US. Other environmental factors, and I kind of alluded to this, and this is classic for us in Northern New England, is there's a pretty customary seasonal predisposition to issues. So if someone comes in and says, you know what, I have an issue springtime every year, based on my experience, I can pretty much guarantee that person that they're going to have issues to tree season, tree pollen. Up here, we have high prevalence of birch pollen. So the spring season, you think of tree issues. The summer season, you think of grass issues. And the fall, which we're in now, is ragweed, predominantly, but that's the weed season. So spring season here, to prevent symptoms and prevent with medicines, I usually have people start with treatment early to mid-March. I think peak tree pollen, which you can have apps on your phone that track that, is usually, April to May. Summer season with grass is going to be mid-May to like July, and then July onward and into August we're going to start seeing weeds already. What I'd like to point out though is those are the easy things, but people often forget that there is a strong cross reaction with foods. So let's use that patient that has issues with springtime allergies, and we know that they have birch trees all over their yard, and they go out for springtime hikes and they come home and they feel terrible. I often remind them that there is a strong correlation to what they consume. And what we call that is cross reaction. So there are certain foods that your immune system will treat very similar compared to that environmental exposure. So for example, let's take birch pollen. You may be sensitive to the springtime birch pollen, but also we know through research that peach, apple, cherry, apricot, pear, and some nuts, but especially those pitted fruits, cross-react with the immune system, which means your immune system, if you have an apple in March and you have tree allergy, your immune system is going to treat that apple exposure very similar to a birch exposure and kind of form an additive reaction. So many people that don't realize these dietary links that then bombard their immune system in their diet intake, plus the environmental factors, that leads to exacerbation of illness, whether they think they're have an upper respiratory infection or sinusitis or an ear infection. And that's too much for the immune system to kind of keep in check. And then you have these disease flare-ups. So the big thing is the pitted fruits in the spring. So I would say if you have a spring issue, avoid that in that time of year. Summer classically will cross-react with carrot, the beans and the legumes and watermelon. And then in the fall really is melon, banana, obviously the fall related, vegetable, especially zucchini and squash, cucumber, and again, watermelon. So this isn't to say you don't eat these foods, but if you have an issue seasonally, and I often see people that come in and say, you know what, I only have issues in the fall. So the simplest thing to do would be take medicine in the fall and then try to avoid or limit the consumption of these foods that could also trigger a similar reaction. Are allergies more common today? It's a good question. Allergy rates we know have doubled since the 70s. We know that they continue to rise in children and adults. And again, we talked about hygiene hypothesis, increased knowledge, being aware of kind of symptomatologies that may not be super life altering, but they're annoying. And then the newest thought is, global warming. Global warming is going to shift likely the season, and what we thought was maybe an early fall or a late spring or early summer. The times of these seasons may alter a little bit as we see some climate change. But that's a very controversial thing, and I don't want to get into politics for sure tonight. But those are some of the things that the community watches for. Again, this was one of the questions I asked in the beginning. Can an allergy be cured? And it's no. The answer is no. But there's many ways to treat the allergies. Classically, over-the-counter Zyrtec and Allegra in my practice seem to be the preferred most beneficial antihistamines. Claritin I find to be the worst. Usually my method of treatment is first in the nose, because that's where you're encountering these allergens. So we maximize the nose with a sinus rinse, maybe a medicated spray. If that's still not enough, then I typically would add an antihistamine, which again is the Zyrtec and the Allegra. Sometimes a medicine called Singulair, which helps with the lungs. And then if that still isn't good enough, and allergy involves people's lives for more than maybe a season of the year, then we say, you know what, is there a better long-term option? The long-term option we call immunotherapy, and that helps to not only alleviate the symptoms, but really gets at the immune level problem. Immunotherapy is the only way to change your immune reaction, to tell your immune system that whether it's cat dander or dog dander or grass pollen, take whatever example you want, we have a way to desensitize your immune system so it no longer looks at those allergens as a problem in the future. So it's the best long-term mechanism to use. especially with those people that have developed lower respiratory issues like asthma. So the immunotherapy we offer here locally after testing, we can create custom serum for injections, which is a process that's been around a long, long time. I myself did that through residency and really got my allergies much, much better. I grew up with terrible allergies as a child. And then we also have a way to treat that with drops, and that's called sublingual therapy. So again, if you want to help treat small parts of your symptoms throughout the year, if it's a very small time frame, I would focus on the nose. I would use a saline rinse. I would use a medicated spray. If you need additional help beyond that, then you turn to oral medicine, and I would try the Zyrtec or the Allegra first over the counter. So these help to control the histamine release that we talked about back, that attached to that IgE molecule. And again, the histamine leads to the itchy, watery, congestion, sneezy. And then anti-inflammatory drugs really are sprays in the nose. We really use those because uncontrolled inflammation really then leads to sinusitis. And that's what we want to try to avoid. Again, immunotherapy is the only long-term way to change how one reacts to those allergens. If you choose allergy injections, it's weekly shots. If you choose the sublingual or the oral drops, that can be done. That's a daily process, but it can be done at home. Traditionally, we see about 85% success with this over 5 years. But it is a significant investment in both time and patience because it's not a quick process. It's not like turning on a light switch. It is a slow escalating dosage and concentration that allows your immune system to change slowly over time to produce really accommodation. And it's that accommodation that really tones down the level of excitability that your immune system portrays to certain allergens. So really the goal is to reduce the need of medications and replace it with the immunotherapy, reduce upper and lower respiratory infections, and really improve asthma-like symptoms. So that is all I have for specific data. I wanted to keep that to a half hour, so not to bore anyone, and I think we're right at there. So my practice, again, we have 3 offices. My main office is in Littleton. We have an office in St. Johnsbury, Vermont. We service allergy patients both in St. J as well as Littleton, and we've opened up a 3rd location in Plymouth, which is building nicely. And ultimately, we hope to offer allergy service south of the Notch as well. So my office number is there. Traditionally, we ask for primary care, referral to help evaluate patients. We want to include primary care in the decision to seek specialty care. So we often ask the primary care doctors to send us a referral request. We'd be happy to see you. We'd be happy to come up with a specific treatment plan or evaluation of your specific needs. So I want time for questions, and I would be happy to answer anything right now.
So we did have one come in while you were talking about some of the treatment medication options, and another commonly heard one is Flonase, and this individual wanted to know your thoughts on the use of Flonase.
Yep. So Flonase is over the counter. The drug name is fluticasone. It's been around forever. Most of the nasal steroids are very safe to use, and thus they've gone to over-the-counter means of trying to reach them. Flonase is an intranasal steroid aimed at reducing inflammation with direct application. And it's a very good approach initially after using some saline to rinse, blowing the nose, and using that intranasal steroid. And really is the first step of treating any allergy. So I always tell people, why take a pill to get to your nose? So we can use pills if we have to, but sometimes the simple process of a good rinse, which I use, and I recommend a sinus rinse kit, it's called, that's also over the counter, in conjunction with a nasal steroid like Flonase or Nasonex. Those are very similar products. That's very safe to use. I say safe because people hear the word steroid and get concerned, which is good because some steroids aren't as safe, but this is very locally acting, meaning it doesn't spread throughout the body. It doesn't go to your organs. It doesn't build muscles. It doesn't cause the side effects of oral steroids. They've been proven safe long-term. A couple contraindications would be very young children under the age of 1. If you have any known intraocular pressure issues, like glaucoma, we don't want to use those in those instances. But for the most part, they're very commonly used and they're very well tolerated. The problem with Flonase, it smells like flowers. Some people don't like that, but before any insurance company will pay for a secondary nasal spray, they usually demand the failure of Flonase because it's over the counter and the insurance doesn't have to pay for it. So that's what they like, of course. So it's a very common first step, for treatment. And then from there, if that's still not enough, then we would add on, some oral therapy. I would discourage some over-the-counter nasal sprays such as Rhinocort and Nasocort. So if you're going to use an intranasal steroid, I would stick with the Nasonex or Flonase. Those are much less absorbed throughout the body. The Rhinocort and the Nasocort aren't. They are absorbed much more throughout the body, and those aren't recommended because I think it would only make sense to use something that's more locally acting. So I would stick to those two if you're going to try something.
Did have another question come in talking about allergies to drugs and medication. This individual recently had a severe reaction to Keflex, which is a strong antibiotic. Should they stay away from all antibiotics now?
So Keflex is a cephalosporin antibiotic. So the quick answer is no, don't stay away from all antibiotics. Use antibiotics if your doctor says you need them. Cephalosporin can be a common allergy. If the reaction occurred within 15 to 30 minutes after ingestion, you can be pretty sure that it's related to that, assuming there was no other exposure. Cephalosporins are linked to penicillin. So more commonly, we'll have patients that are sensitive or allergic to penicillin. And the common question will be, can I have a cephalosporin? About 15% of people that have a penicillin allergy will also have a reaction to cephalosporins, which is the class of Keflex. I would say it's if you're going to have an allergy to Keflex, it's probably not preferred to have a penicillin-based antibiotic. So I would ask your doctor, one, make sure you need it, that it's a bacterial process, because that's the only time to use the antibiotics. And two, steer away from a cephalosporin or penicillin-based just for ease. But if you have a reaction such as a Keflex reaction, the best thing to do is to stay calm. Make sure you tell someone that you're having a reaction. Take at least 25 milligrams of oral Benadryl and kind of monitor your symptoms from there. And of course, if things progress, seek medical help. But just because you have a sensitivity to Keflex doesn't mean that you won't, you can't have other classes of medicine. Back to allergy testing for drugs, there aren't many labs that will test for cephalosporins. So we're only able to test for the assays that the labs offer, meaning they offer penicillin, they offer sulfa drugs, but they don't offer many other classes of antibiotics. So it's really probably worth your while that if it happened close to your ingestion, mention to your doctors each time that you had the allergy. They can include it on your chart, and then future prescriptions, they'll try to avoid using that type of medication. Was there any, if there's any more questions that I didn't answer in terms of what the initial question was, please shout, because I can further clarify if there's still a question.
Another question came in. Can you repeat why older people develop allergies? My husband is 68 and spends a lot of time outside. He suffers from allergies spring, summer, and fall.
Yep. So I'm a firm believer of if you live in this country, you are going to develop allergies either as a child or as an adult. Not many people have I met in my 15 years of practicing medicine that had severe allergies as a child and an adult. And most people that develop adult allergy onset had no issues as a child. The why to that is very good. It's a good question, but impossible to answer. We know that it's harder for me to convince an adult that this is allergy because, again, a lot of people think that it's a pediatric process. It's a childhood process. But what we know is the immune system does change. It changes with age, and no different than how the immune system keeps in check rapid cell growth for cancer. That's the example I use always. Why does someone get cancer at age 40 versus 60? And at some time, your immune system alters. It doesn't perform like it did, and we have the result of disease. And this is no different. The immune system changes for whatever reason, and adult onset allergy is a real etiology, and I would probably say half of my practice is related to that onset. We test them. Adults are easy because we can skin test them. That skin testing takes about an hour and a half. We get answers that day. We test for all the environmental factors, and then we easily can offer immunotherapy. So for this patient, if they have issues all year, the downside of using medications is ultimately your body's going to become accustomed to them, and they're not going to work as well. So the long-term answer for this patient would be identify the problems with the data, which is by allergy skin testing, come up with a plan that's feasible, whether injections or by drops, and giving that long-term relief. Because if you're having issues 3/4 of the year, the medications really is not the preferred option. It does help symptoms, but it doesn't fix anything long-term.
Let's see. Interested in more information about cross-reaction foods. Is avoidance just while they are in season? What if someone has year-round allergies?
Yes, so cross-reactivity is something that's studied based on aeroallergens, which is environmental pollens that are airborne. So we don't have cross reactions known to pet dander or mold or dust mites, but anything that you inhale that's flying around the air, there is pretty dependable data that shows what the immune system, what it can mimic to the immune system. Obviously, we don't have tree pollen all year. So those people that have allergy symptoms all year, there's probably a wide array of positivity. So our environmental panel, we look at probably 45 different allergens. I bet you that person that has all year round allergy is going to have large positive results in a whole array of those. So certainly what we tell those people that would have a positive mold issue is there's a lot of moldy foods. We have a specific mold elimination diet. Ketchups, mustard, relishes, anything canned, anything pickled with pickles. There's a very strong list of high mold content foods. So if people have a mold environmental positive test, not only do we want to deal with their environmental exposure, but we then educate them on how to avoid molds in their diet. And of course, that's all year round. If someone's specifically worse in the spring, they don't have to avoid those pitted fruits, necessarily all year. But when the environmental pollen is high, they want to steer clear of those because that may tip the scale, and the immune system will kind of have an extra overzealous reaction, and they'll have issues. So what's hard for people is if they have multiple seasons, and then you want to try to steer clear of those foods in those seasons, as we said. So pitted fruits in the spring, the fall really is the zucchini, the watermelon, the carrot. and the grasses, you know, as we listed on the survey. So we tend to go through those often with people, and we remind them of the in-season foods, but certainly if you have an apple in January in the North Country, it's not going to cross-react and deal with birch pollen because there's none of that around.
I'm not seeing any others come in. So again, feel free to use the question and answer function or the chat function at the bottom of your screen to type in questions or comments. I have a question. I had my tonsils and adenoids removed as a young adult, and I actually seem to have improved seasonal allergies since those procedures. Is there any correlation, or is that not a thing?
It can be a thing. There's not probably a direct correlation, but tonsils, adenoids are big lymph tissue. So certainly uncontrolled allergy or allergy prone reactions can inflame that type of tissue, which then harbor bacteria, which then create symptoms. So the fact that you kind of get rid of those areas that inflammation likes to involve, you kind of reduce the source to the fire, you know, so you could think of it that way, where, you know, you don't want to leave the you know, all the leaves on the grass for a risk of you know, a grass fire. So you remove the leaves, you can still get a fire, but it's not certainly going to be as prevalent. So the flip side, though, we don't have people with allergies and tell everyone they need tonsils and adenoids out, right? So it's not a reverse correlation, but certainly if your nose is inflamed and it's prone to have congestive issues from inhaled allergens, the adenoid pad is a perfect spot for all that stuff to collect and cause issues. So I would say there's a loose correlation there. And I think I screwed up my video, so I apologize. You can't see me any longer, but I did something with my computer, but I'm not that savvy to fix it. But I think you can still see my lecture. So thanks for everyone attending. Again, we're only a phone call away. We try to really help primary care doctors as they have questions. We'd be happy to see you at any of our locations. And again, I'm a positive, you know, proof history of allergy injections. Our daughter takes allergy drops, so I've not only have lived this from the patient side, and it's quite miserable when you have a long year of allergy type symptoms. People often can't relate until they have it. And thankfully, I was one of those 85% that had a great reaction to those over my 4 years that I took shots, and now I take nothing for my daily allergy. So not only am I an example of that, but you know, we have numerous people that have really changed their health status, because it's not always just the histamine type symptoms. It's overall fatigue, flare up of illness, breathing issues, and it just becomes really, you know, really wearing down over time. So our allergy staff that see people on a regular basis, patients are so grateful for their improvement of their overall health balance and their baseline health. It becomes a very rewarding, you know, part of the ENT practice, and I'm glad we can offer it locally, and we try to make it as convenient as we can, because we know it's a commitment and it is a process. So thanks for listening. My office number is there. Please reach out if you need any more help. Gail and Heather, thanks for organizing this. I'm glad we can still get to the community, and thank you for all your time.
Thank you.